that's because of him, my boss. So, from Allison from ECU.
Well, good morning. Thank you for coming this morning. I'll try to end on time so that we can get to lunch. It's always a pleasure to be in Rio. It's such a beautiful place. It's always hard, though, to give a talk after Dr. Bagnato, since he's such a smart guy. Makes everybody sound quite stupid afterwards. So we're going to talk about clinical aspects of PDT, perhaps. Yes, thank you. And photodynamic therapy is not something that's new, but it is something that's very simple, and the beauty of photodynamic therapy is its simplicity. So it's something that can be done any place in the world without the need for very expensive operating rooms or facilities. And it's an organ preservation type of treatment. So it's an outstanding means for cancer therapy anywhere in the world. And what PDT really is, it's a drug that's generally introduced to an individual, the appropriate wavelength and energy of light, and that leads to a reaction. So PDT is a drug, a light, and a reaction. And what we call the drug, instead of a chemotherapy agent or an antibiotic, we call it a photosensitizer. And there's no real clear reason why, but generally these photosensitizers that are successful in the clinic accumulate to a certain degree more in tumors and are cleared a bit more from normal tissues. The mechanism of that is not 100% elucidated, but it seems that successful sensitizers have this as a characteristic. Once you have the sensitizer in an area that you want to treat, you then illuminate that particular area. So the other aspect of PDT, which is interesting, is that you're just lighting up for a reaction in this anatomy that you wish to illuminate. You're not illuminating the entire body at this point. And usually the light source has to have enough energy to activate the drug at the appropriate wavelength, and that is generally a laser, but it doesn't have to be. And this creates a cascade of reactions, which is termed the photodynamic reaction. So the sensitizer accumulates, you use the correct light, energy, and wavelength to activate the sensitizer, and then you hopefully result a photodynamic reaction, which is cytotoxic and vasculotoxic and destroys the tumor. What's interesting about PDT, as opposed to other oncologic therapies, it's generally not a mutagenic or carcinogenic type of therapy. Depending on the sensitizer and the light source, it's generally a painless sort of treatment. It can be done as an outpatient. It can be repeated many times. But the best part of PDT is that it generally works and works quite well. So PDT can be used not only for therapy, but for diagnosis as well. That's on the other side of the light source. So what other type of therapy can tell you whether you're having successful treatment during it? And this is just an example about how you can fluoresce tumors and understand where these tumors are, and might find other areas which you might not have seen or not appreciated as well under regular light. So photodynamic therapy and photodiagnosis work hand in hand to produce what could be an excellent cancer treatment. So what is a successful photosensitizer? Well, it's something that's generally reliable and it works when you want it to work. It's something that is not toxic to the individual when you're not treating them. It's something that's not really there to tell you that it's causing pain and grief to the patient or to the staff. But the most important part of a successful photosensitizer is for it to be commercially available. There are thousands and thousands of compounds that can work as photosensitizers, but there are only a handful that are commercially available. And some of the very best photosensitizers you can't use on patients yet because they're just not being manufactured. The light sources too. What you want is something that's flexible, that you can illuminate any place in the body, that doesn't cost an arm and a leg, that your entire budget is spent buying one of these light sources. So having a commercially available light source is an excellent means of successful photodynamic therapy. Ultimately, once you have a sensitizer and you activate it by your light, you're creating this reaction, which is based on singlet oxygen. So hypoxia will stop your photodynamic reaction. Oxygen is a key component to successful photodynamic therapy. What's not really appreciated as much, but will come in the near future, is that not only are you starting a reaction locally where you're illuminating, but depending on how you illuminate and the type of energy that you're using, you can release cytokines and other types of tissue reactions and get a systemic and regional reaction. So photodynamic therapy, even though it's a local light source generally, depending on how you're offering this treatment, can have regional and systemic effects. So what do photosensitizing agents really do? Well, they take the energy from light and they transfer it. And they transfer it to create this reaction based on singlet oxygen. And every photosensitizing agent has its own characteristics. And if you're familiar with one, it might give you some idea how to use another, but they can't be interchanged. There's a learning curve for each one. The most common one used around the world is Photofrin, simply because it's been available for about 30 years. And this is a porphyrin, and most of the photosensitizers that are commercially available are in the porphyrin family. It has multiple activation wavelengths, but the activation wavelength that we generally use clinically is 630 nanometers, which is this red wavelength. And the reason that we use the red wavelength is because it penetrates skin for at least 1 centimeter. So this is a clinically useful sensitizer with a clinically useful wavelength. It's not a toxic sensitizer. It has a large patient base that has been tried on. But the problem with Photofrin is it stays in most tissues for a very long time. So even though it concentrates in the tumor, it's also in normal tissues, particularly your skin, for 4, 6, 8 weeks. And if you're in a place where there's a lot of sunlight, like Rio, having to stay out of the sunlight to prevent this photosensitizer from activating, that's a change in your lifestyle that might be too difficult for some individuals. The other aspect is it takes 10 or 20 minutes to actually do a treatment. So that's okay if you have 1 or 2 lesions, but some individuals might have 10, 20, 30 lesions requiring treatment. This is the structure of Photofrin. It looks like hemoglobin because it's related. This is the most interesting aspect of Photofrin, is that it's very active at a wavelength of 400, which is about blue light, and blue light only penetrates skin about 1 millimeter or 2, so it's not that clinically useful. But where Photofrin is very active for us in red light, it's not very powerful. So even though it works, it doesn't work that well. And based on the fact that it doesn't have that really significant ability to transfer light energy, a whole series of other photosensitizers have been created. The other one that's quite common in the United States is called ALA, and this is a prodrug. It's transformed into protoporphyrin 9, which is an active photosensitizer. It's quite good with the blue light system, and it is used for a lot of skin lesions in the United States. It's topically applied. There's a very potent photosensitizer called FOSCAN, which is commercially available. It has a very, very potent ability to create singlet oxygen. So rather than treating for 10 or 20 minutes, you treat for 10 or 20 seconds. So a drug like FOSCAN has a great deal of potential in the clinical arena because sometimes it's very difficult to get a light source stable on a lesion for up to 20 minutes. FOSCAN also has a little bit less sunlight photosensitivity. There's another porphyrin member called VERTIPORFIN, which is used in the ophthalmologic field. That also has very high singlet oxygen. It's very interesting that that treatment also is done in a matter of minutes, but that drug is cleared from your body in a day or 2. So all of these drugs are commercially available, and depending on if they're available in your country, you can choose among them for any individual patient. But because these drugs are commercially available, there are a lot of other companies producing a lot of other drugs. So over the next couple of years, you might find that there are many new drugs on the market. Again, each one has its own characteristic, each one has its own wavelength of activation, and the reality is that they're not always available. So even though there are a lot of companies working on these things, you might never be able to treat a patient with them. So once you have a drug, then you need to have a light source. So the sun is the most powerful light source that we have available these days, but it's much better to treat somebody inside than to have them stand outside. The reason the sun is also so dangerous in PDT is that it has all the wavelengths available for any given photosensitizer to activate it. So one of the great things about PDT that you have to always ask a patient is, will they stay out of the sun for the appropriate amount of time? Otherwise, it's not a good treatment for those individuals simply because the sun will activate that sensitizer. Up to about 5 years ago, these were the type of illumination tools that you would use. They were about the size of refrigerators or these desks. They weren't very mobile. These are still used in many places because they're very good, reliable machines. But in hospitals, it's hard to have things that are that large and bulky. More recently, you have suitcase-sized lasers, and this is an interesting one that's commercially available around the world. It has a port. You bring a fiber optic. You can see these fiber optics are rather small. They're flexible. They can be put into any scope, so they're quite good not only for skin treatment, but for any part of the body where you can manage to put the fiber optic. They also have a computer calculator for you that allows you to calculate the time of treatment. So once this became available over the last couple of years, photodynamic therapy has grown by leaps and bounds because you can carry this laser with you. It doesn't need special electricity, special heating, special cooling. So things like this have moved the field forward. This is now out of date, really, because most of the lasers are about the size of your hands. And you don't really need lasers. Lasers are expensive. You can just use filtered fluorescent lights, depending on the drug. So you don't actually need a laser. LEDs, fluorescent lights, all of these are commercially available and quite good as light sources for PDT. Fiber optics are important in the sense that not every lesion is right on your skin or in your mouth. There are deep lesions in your pancreas, in your biliary tree, down your esophagus, down your airway. To have a flexible fiber optic that can go through these scopes has been a key improvement in photodynamic therapy. The problem is they're not always commercially available, but sometimes there are engineers who can make these for you. Most fiber optics that are commercially available have two types of end pieces. One looks like a flashlight, which will project light forward. The other is a diffuser, like a light bulb, that'll send light in all directions. Generally, between those two, you can get a good clinical treatment, but certainly not optimal. Sometimes you'd like to have a circular light source. Sometimes you'd have to have like a hemisphere, but these are not commercially available. Once you've got that all down, what you're really doing is entering light energy into your sensitizer. This is in the case of Photofrin. That's changing the state of Photofrin, creating these singlet oxygen species, and these radicals are very nasty to anything in them where they're activated, which is generally cells, membranes, or vascular membranes, and they destroy them cells' membranes or the blood vessels' membranes. So the photodynamic reaction, in summary, is a singlet species which is cytotoxic, vascular toxic, and also induces apoptosis. There's a regional reaction that can be released if these cells are destroyed rapidly with these cytokines in complement, creating an immune cascade, and this creates a systemic reaction. So it's really quite possible to use PDT as a means of vaccination, if you'd wish, by upregulating proteins. So now that we know all we need to know about PDT, what do we really do with it? Well, there are quite a few variables, despite the fact that it's just a drug, a light, and a reaction. And basically, once you've got a working light source and working photosensitizer, you now start to manipulate some of the drug concentrations, the light intensity, and what we call the drug-light interval. In other words, the time that you inject the drug or apply the drug to the time that you illuminate. So depending on where you are in using these different drugs, the drug-light illumination period can be a few hours or a few days. So if you're planning an operating room procedure where you're injecting the drug 3, 4, 5, 6, 7, 8 days before the procedure, you always have to think ahead about reserving your room, making sure it's not a holiday, making sure you don't inject on a day that you have to illuminate on a weekend. So all of these things are things to think about. The major thing about photosensitizers, if you have a choice in them, is do you want to use a topical photosensitizer or an intravenously introduced sensitizer? If you're using a topical sensitizer, you'll generally get only photoreaction wherever you apply the photosensitizer. If you're using a systemic photosensitizer, it will go everywhere in the body, but generally concentrate in the tumors. The major difference is, if you don't recognize where the tumor is and you apply something topically, you might miss half of your treatment field. Whereas if you do it systemically, the sensitizer is much smarter than we are, and it goes to where it's appropriate. So topical application is, if you know where you're supposed to treat, it's a good way of doing it. You can get very confused if you don't apply it to all the different types of topical lesions that you might want to treat. But the most important part of the topical photosensitizer is it doesn't go very deeply. The commercially available drug ALA only goes 1 millimeter or 2 into the skin, so you can't really use it for deep lesions. Systemic application of a photosensitizer, whatever one you're using, lets you treat to the depth of the lesion because systemic photosensitizers go everywhere. Again, if you have the choice, you can make a decision about which way to go. If you're using intravenous or topical, depends on the situation. You don't want to make somebody photosensitive if you can treat a small spot. You don't really want to just treat a small spot when you have to treat a large area. So the first thing to think about is what type of sensitizer to use. Once you're treating a topical set of lesions, you always want to identify which lesions you've treated. It's simple if you've got 1, 2, or 3 lesions, but again, some patients have 20, 30, or 40 lesions that require to be treated. Generally, you don't want to treat the same lesion twice because you're going to create a very, very severe side effect that way. A second aspect of the technical part of PDT is that how you illuminate will give you the reaction. What you're trying to do is generally do a homogeneous illumination. In other words, you want that light to come out as a fan right into your lesion, give every part of the lesion the same amount of light. And that's very good if your incident light comes in flat on the surface. But how often is the body flat? Patients are in respiration, if you're deep down through a scope. So quite often what you find is you're giving inhomogeneous illumination. And this is one of the great drawbacks of current PDT is that you know what you want to do, but you can't actually technically do it as well. And this slide just shows how nice and even you can illuminate things, but if you're just off a little bit, you'll screw up, overdose one side and underdose another side. So this is a technical consideration, and there are some lesions that you might want to treat with PDT, but just their location won't allow you to illuminate. So this is as simple a treatment as possible, really, and you can see here you're just illuminating. Now, here's a technical error in the sense that this one is coming in at a pretty sharp angle. To your eye, everything looks the same, but to the tumor and normal tissues, this is a different dose here than it is here. Plus, there's overlap. So this is something you don't necessarily want to do in real life when you're doing treatments. So the art and science of PDT is that even though you have a drug and a light, is to determine how to give the drug and when to illuminate. If you have a very vascular tumor, the drug generally goes to vascular objects first, so you can illuminate very quickly. So if you have a liver tumor, which is vascular, you can inject and treat very rapidly. If you have something on the skin, which is generally not a vascular tumor, you wait a few days until the normal tissues clear. So these are the variables that you're going to do. What also you do, that doesn't seem to be there in the right spot, is you could do a concept of photobleaching. Ultimately, in radiation oncology, for example, you know the dose that you're giving, you know the reaction, you know the interactions of the photons of radiation. In light, you're not 100% sure what the dosimetry truly is. So one of the things that we do a lot of is called photobleaching. In other words, we use as little drug as possible. So theoretically, the drug concentrates in tumors to a greater degree than normal tissue. If you use just as little a drug as possible, the normal tissues should have a sub-threshold amount of sensitizer, while the tumor beds have just enough to be destroyed. So photobleaching is what we do. In other words, if you're using a lot of drug, and that doesn't come across too well, normal tissues will have drug and tumor will have drug. Yes, the tumor will have a little bit more drug than the normal tissue, but you're going to get a lot of reaction everywhere. If you use low drug concentration, the normal tissue doesn't have much drug, the tumor has quite a bit of drug, and when you're illuminating, your normal tissue will have very little reaction, but your tumor will have a great deal of reaction. So there's, until dosimetry is worked out quite well in PDT, we suggest using as little drug as possible. Once you have that, you have the drug, the light, and the illumination. The illumination creates a reaction. If this reaction is near somebody's airway or near somebody's eye, you might want to use some steroids to try to decrease the swelling. So there's some considerations as well that way. Let's go into the clinical overview now. Again, PDT in the clinic is as simple as bringing the drug in, waiting for the drug to concentrate in the tumor versus normal tissue. Every drug has a different amount of time that this takes. And then once you're feeling confident that the drug is where it's supposed to be and the normal tissues don't have much drug in them, you illuminate and create the singlet oxygen reaction. You can treat cutaneous lesions, and the modern era of PDT was born with clinical treatments of cutaneous lesion. This is one of the first reported PDT treatments from around the turn of the century. So PDT is not really something that's very new in the sense that you can do very good treatment with very primitive light sources and drug concentrations. And this is the same thing that you can do today. So this drug that was used here were dyes. Those dyes are the same dyes that we use in ink. So you can do very good PDT just by putting some ink on your skin or a lesion and going out in the sun and burning that off. You don't have to see a dermatologist. In the United States, PDT is approved in the skin only for actinic keratosis with a topical cream. So even though PDT can be done with Photofrin or whatever drug you might have, in the United States the only way that it's approved is with this DUSA blue light system, and it does a very, very fine job. There are other off-label treatments that you can do with basal cells. The problem with basal cells is sometimes they're deeper than 2 or 3 millimeters, so you use generally Photofrin for basal cell lesions. There's FOSCAN, which is not available in the United States, but in Europe, FOSCAN has been used for any number of skin lesions and has worked quite well. And again, in the United States, ALA PDT is not available, but in Europe, it is available for basal cell carcinomas, and it does a very good job at clearing things. This is just a typical treatment that we would do. This is an individual who had a lesion at the tip of her nose. The margins weren't clear. That individual was going to have what's called Mohs microsurgery to the tip of the nose. What that means is your nose gets put into a slicing blade, and your tip of your nose continues to get sliced off until there's no lesions left. And what happens then is you're missing half your nose, so then the plastic surgeon has to come in to rebuild your nose. So this individual didn't like that idea. So what we did is we illuminated the tip of the nose, and as you can see, 2 years later, there's no lesion, plus a very beautiful cosmetic result. So PDT works very, very well for skin lesions. Here's a FOSCAN lesion that was treated. There's the lesion, there's the illumination, there's the clinical response. It's really quite excellent. To do this treatment probably took about 20 seconds. Very simple. This is a larger lesion, a basal cell, again FOSCAN. There's the lesion. Here's FOSCAN, 20 seconds worth of treatment. After about 2 months, you get a very, very nice response. But what you might want to notice here is wherever they illuminated with this drug dose, they got a very, very intense reaction. So there's not all tumor here. So if you use the wrong drug dose or the wrong light dose, you can get a very, very severe reaction. In this case, the person got away quite well. But what this slide shows is that you really need to manipulate your drug and light dose if you want to get away with anything better than luck. Squamous cell lesions. Again, you can treat a squamous cell of the skin with PDT. This is what we typically treat with PDT. We don't get small lesions. We get these very nasty things. And because there's calvarium or bone there, we use a little bit of Play-Doh to block the light from over-treating the bone. But this is the whole treatment. Just turn on the lights. It's all done. This takes about 20 minutes with Photofrin. It would take about 20 seconds with FOSCAN. This is the individual 15 months later. He didn't want to have the hole in his head, so he had a flap placed. But basically what happened was he got a 20-minute procedure. It killed off that giant tumor. He didn't want that central part of the bone, which the tumor had eroded into, to show, so he had a second procedure. But that is something very simple that can be done with PDT. Here's an individual, again. He had a pre-malignant melanoma lesion here. We illuminated it. That's all there is for the illumination. You just don't want the scatter dose to go into somebody's eye. Again, that drug is everywhere. It's concentrated in the tumor, but it's everywhere. Anytime you have an intense source of light, it'll activate the drug, so you don't want that light activating in the eyes. This is what you see when you have a very nasty lesion and you're trying to burn it out with PDT. He had a second lesion behind the ear that we treated. And very nice clinical and cosmetic response. That was biopsy. That's just a little bit of melanin that was left over from when the cells died off. You can also treat things like Kaposi sarcoma and melanoma with PDT. As I showed before, Here's another melanoma with satellite lesions. This is a very, very nasty sort of thing. The surgical procedure for that is to have your top of your scalp removed with the bone, have reconstruction, have radiation, have immunotherapy. You're still going to probably have systemic spread of disease, so you have a very terrible destructive lesion and a destructive treatment. Instead, the fellow had PDT. That was a 20-minute lesion treatment. Here he looks like about a week later, some reaction, but he still got his skin of his scalp. And this was biopsied 24 weeks later, a little bit of melanin left over, but no actual tumor cells seen on pathology. He had no local recurrence and did quite well, actually. So here's a guy with a 20-minute PDT treatment who otherwise would have had a very, very significant surgery, radiation, and immunotherapy. He got away with some good luck. This I'm not sure if it shows too well, but these are Kaposi sarcoma lesions around an eye. That can be treated with radiation. It's quite a difficult treatment with radiation to do it right and leave functioning lacrimal apparatus and things like that. Here is a single PDT treatment. I'm sorry that we can't see it too well, but you can make out he still has his eyelashes. So it's very straightforward. It's a very good treatment for certain individuals. We do a lot of stuff for breast cancer, and the problem with breast cancer, once you fail conventional treatment, you get stuck in a quagmire with these very large lesions on the skin that don't seem to want to go away and start to grow. And you can try to salvage these patients, and I recommend you try to salvage them with surgery and radiation, but a significant number of these individuals continue to fail. You can do very heroic surgery by removing the chest wall. You can do very heroic radiation by overdosing the chest wall and getting into trouble. It's very rare for chest wall lesions to respond when you get to the third and fourth chemo agent. So what we have been doing is PDT for these individuals, and we do this as an outpatient procedure. It doesn't necessarily stop any other chemotherapy, radiation, or surgery from going on. And what we do generally is use off-label Photofrin at a fairly low dose, 0.8 milligrams per kilogram, rather than what's standard as 2 milligrams per kilogram for those of you familiar. And the reason for that is basically from those slides before, where we try to use as little drug as possible. So we've treated about 600 lesions, always as an outpatient, but because Photofrin is not the most active drug, it takes a half or a whole day to do this. And if the illumination causes some tenderness, we use ice patches. But it's really quite a well-tolerated procedure. And what we found is that most of the lesions either go away completely or stop growing. And we follow these patients out quite a distance now. So the treatments are given. These patients have gone through the ringer, so they don't go out in the sunlight. There's no photosensitivity. There's good pain control and good lesion control. So let's see. So here it doesn't, it's very nicely illustrated here, not as well here. This is a scar with some lesions on it that has failed surgery, radiation, and chemo. Here we have illuminated. You can make out where our extent of illumination is, yet you see more reaction where the lesions were. So that shows that we took a very good drug dose and a very good light dose. And this is what this individual looks like about 2 months later. So despite the fact that this individual's had about 10,000 centigrade of radiation, surgery, all the chemotherapy agents known, they have a very good clinical and cosmetic response. We like it when we see them along a scar with individual recurrences rather than conglomerates. This lesion right here is eroding into the sternum. So for this individual to have a treatment with surgery, they'd have to have their sternum removed. So even though it looks like a small lesion, it really isn't. Yet for PDT, it's a fairly straightforward illumination. Again, you can make out the edges of where we treated, and you get a more intense reaction within 24 hours. And then the lesions go away if you do the treatment right. Again, this is what we usually see, very, very nasty, gigantic chest wall recurrences that hurt quite a bit. And in select patients, it actually ends up healing. That same patient had lesions on their back, cutaneous metastasis. So not only can you treat the front, but you can treat the back at the same time. You can get a very good reaction for skin. So chest wall, PDT, breast cancer patients, when they fail everything, PDT is still an option. You have to use the right drug dose, light dose, a little bit of good luck and some skill. But these are the things you can do with PDT that you can't necessarily do with any other treatment. Going for the rest of the body, you can use PDT in the brain. You can do PDT right during surgery. If you give the sensitizer 2 days before, what happens is the surgeon will go in, they'll remove the tumor, they can fluoresce to see if there's any lesions left, do more resection, or they can illuminate with a light source. Head and neck tumors, again, what happens here, head and neck tumors are generally treated with radiation and chemotherapy, radiation and surgery, surgery alone. It's a very morbid procedure. PDT works quite well for head and neck tumors. Here's an individual who had a lesion on their tongue. This was going to be a fairly extensive surgical resection. It was an older person. They decided to have PDT. Again, PDT is a local treatment. If you think there's lymph node involvement, you're not doing the patient a favor by just doing a local treatment. But in this particular case, we did a local treatment, got a pretty significant reaction through wherever we illuminated, but fairly soon afterwards had a much more select response. So again, if you're using the right drug in light dose, within about 2 weeks after treatment, you have very good healing and a very good response, and that patient had local control and never had a problem again. You can do PDT for the lung, for in situ, endobronchial diseases, advanced diseases. Again, it's the same drug, light, and reaction. There are many other things you can do in the lung with ablation, such as YAG laser, cryotherapy, HDR brachytherapy, and PDT is just one of many options that works quite well. There's a number of larger studies in the lung because the lung is FDA approved in the United States. This is a Japanese study with 240 patients. Basically, they had gotten a complete response out to quite a while in about 85% of the patients with good pulmonary preservation. Another large study by Mugisi showing about 80% of the patients were doing very, very well for a very long time. This is what you generally see. This is a scope. This is looking down the bronchus. You should see an open airway. Lo and behold, it's out of focus there. It's much prettier on the screen. There's a big lesion that shouldn't be there. Again, just another view. You should just see dark airway. I'm sorry it's not projecting well. But there's this big lesion right up there. You enter your fiber into the tumor area. You turn on the fiber, generate a lot of light. About 20 minutes later with Photofrin, the treatment is done. And lo and behold, you have a nice open airway if the treatment has gone successfully. So PDT is quite good for these types of lesions. You can also do spectroscopy to determine whether these are benign or malignant tumors. And then you can also illuminate. So there's many ways that you can treat with PDT in the lung. It just doesn't have to be a diffuser. You can do a micro lens. Biliary disease and pancreatic cancers don't do well no matter what the conventional treatments are. You can take a fiber optic, slide it right in, reopen the biliary drainage, do a very, very good palliative response with PDT via endoscopy. It's outstanding. It's not done too often. The esophagus generally is a very fatal type of tumor. You can turn on the light, open up somebody's esophagus, they can swallow. The whole treatment takes about 20 minutes. There is in situ disease called Barrett's esophagus. The standard treatment for Barrett's esophagus, which is in situ disease, is to have your esophagus removed. That is a very traumatic type of experience. Why not just turn on the light, 20 minutes later have the Barrett's esophagus destroyed by the PDT, and you're swallowing within a week or two. It's quite a bit different. Anal cancer can be treated by PDT. All of these things have very barbaric standard therapies these days with surgery, radiation, and chemo. So PDT allows for sphincter preservation. Prostate cancer, PDT might be something done in the near future. There are studies on it right now. What are the precautions to PDT? What are the problems? Well, every sensitizer has its own characteristics. Some are not active, some don't work well, some are very, very potent, that they can burn a hole within a few seconds, and some cause a lot of pain. So again, just because I'm telling you that PDT works doesn't mean it works with every single sensitizer that's available. The toxicities are basically edema. You're causing swelling. If you're causing swelling on somebody's elbow, it's not a big deal. If you're causing swelling in somebody's airway, it's a big deal. So you have to be careful about edema. You can treat that with steroids, but if you're going to block somebody's airway off, you might need to do a temporary trach for that individual's. Pain management, again, Photofrin generally doesn't cause much pain. Other sensitizers cause a great deal of pain. You might have to give narcotic analgesia depending on which type of sensitizer you're using. The toxicity that we're most concerned about, but often doesn't occur, is phototoxicity. Again, the drug concentrates in tumors but goes all over the place if you introduce it intravenously. The result is, if you go out in the sunlight, as long as there's some drug in your skin, you're going to get a very, very severe reaction. For Photofrin, that's 4, 6, 8 weeks. For FOSCAN, that's 10 days. For others, it's less. Again, you don't want to give this drug to an individual who's going to bypass this very important precaution. You're opening a wound in some people by destroying the tumor, then the body heals up. Is that wound going to get infected? Does that wound need debridement? These are some of the issues, too, that you want to work together with a surgeon if you think you're going to cause a great open wound on some individuals. So what's our summary? Basically, before you think about PDT, you have to ask yourself, is this the right sensitizer for this individual? Do I have the right light sources available? Is the fiber optic available to go and treat where you want to treat? Can I position the patient appropriately? Can I put the light appropriate on that patient? Is that patient going to stay out of the sunlight after I do the treatment? If I'm going to give a treatment, do I have a pleasant room that's clean and quiet? Or do I have room where people are running in and out and the patient's going to start shifting and the light field is going to go off? Do I have sunlight precautions? Do I have goggles for everybody in the room just in case the fiber optic slips and one of these very potent light sources goes into somebody's eye? Do I have goggles available for the patient too? And one of the most important things is that after the patient has finished treatment, do they have a phone number to call you as the physician? Because if they go into an emergency room and they said they had a PDT treatment, nobody's going to know what they're talking about. You can also use the same reaction that we use in oncology for benign diseases. And in the United States, PDT is actually used much more often for benign indications than it is for malignancy. There's a disease called wet macular degeneration that causes blindness. PDT destroys the neovascularity in the eye, stops the blindness from progressing. Cosmetic outcomes, PDT does a fantastic job of rejuvenating your skin. So it's widely available in plastic surgery and cosmetic centers around the country. People will put up with a little bit of pain for that if they get new skin, but they don't like to have pain for their cancer treatments. It's kind of interesting. Acne responds to PDT. You can kill off plaque in your mouth with PDT. You can induce wound healing with PDT by destroying bacteria. So almost anything you can imagine, PDT has been tried for, and it might become commercially available in the near future. So what holds things back? Well, right now, dosimetry, the concept of what's the right drug dose, what's the right light dose, that's alien to a lot of people. On skin lesions, for example, the dermatologist might have 20 different items to treat that. In the United States, billing is quite important. In many other parts of the world, if you're going to spend several $1,000s to buy a drug, you don't want to have to pay for that drug out of your pocket. You'll go bankrupt very quickly that way. And again, PDT is something new and different, really, even though it's been around since about 1900 in its current form. But most people in medicine don't know anything about PDT. So it's hard to start something new. But if you look at PDT as something that complements the types of treatments that you have available and might actually be the best treatment for certain individuals, then PDT fits in very nicely into medicine. So that is plenty. Thank you very much.
Any questions?
Uh-oh.
I am a radiation oncologist, and when you, in your last slide, you put that the dosimetry is an alien for many. I think that when I could know what the dose of light treatment and comparing with the radiation therapy, and when you use radiation therapy, you know the dose, and you know that the dose is limited, is auto-limited. Is something like that in photodynamic therapy too? You can repeat over and over again the treatments?
Yeah, the theoretical difference, is that the PDT doesn't destroy the infrastructure of the collagen vascular centers, so that you don't get the fibrosis and destruction that you get with radiation. Once you reach a maximum dose, you don't get the healing. Well, supposedly with PDT, you never destroy that structure, so that you can always do it. I don't think that's 100% true, but you can repeat PDT even in highly radiated tissues and get more healing than you would have expected. So there's theoretically no maximum dose for PDT, but the reality is, as you mentioned, you can't do it that many times, but you can do it a couple of times even in maximally radiated tissues. So it's very good as a complement to radiation, because you'll get some of these patients where you've kind of hit the maximum that you feel comfortable with, and there'll still be a lesion, and you can use PDT in that same area and not have the same worries. So as a radiation oncologist, you should take into the PDT and find this guy Bagnato up here. He has some drinks for you, and he'll help you set up a PDT center. Thank you.
I have one question for this. You know, the audience here is a lot of radiotherapists. We know a few works that the photosensitizer else helps the radiotherapy result. Can you comment on that? Or?
Well, the rebirth of PDT occurred in a radiation biology lab where they were trying to create radiosensitizers. And the current drug, Photofrin, derived from that as a radiosensitizer. So if you look back in the literature in the late 1950s and early 60s, they were using this drug as a photosensitizer with some very interesting responses. So it's a potential photosensitizer on its own. But what happened was, in the 1970s, Dougherty, who's the father of modern PDT, retired as a chemist and was working in a radiation biology lab at Roswell Park. And the chemicals that he was exploring was this drug Photofrin. And he was told never to put the drug into cells next to a window because it would kill off all the tumor cells. So even though there was this fantastic cancer therapy that these guys had known about for 10 years, he was the first one who said, well, isn't that the purpose? Isn't that what you're trying to do? So PDT was reborn by Dougherty's observation of something that people were ignoring once again. So PDT was born, again, as a radiation sensitizer, and it probably still is a radiation sensitizer, but is now sort of separated. I think it's time to come back to see what can be done together.
Any more questions?
In radiotherapy, in brachytherapy, in bronchial carcinoma, the severe hemoptysis is a big problem. You have the same problem with photodynamic therapy?
Well, the hemoptysis, actually, blood absorbs the Photofrin. So you don't really want to do PDT in somebody who's having active hemoptysis. You don't get as much hemoptysis from a PDT treatment endobronchially. So it's not a common sort of morbidity that you see. You don't really see active bleeding after the treatment. I think it's because it destroys a lot of the neovasculature that causes the hemoptysis, because the drug concentrates in this neovasculature and rapidly dividing cells. So if you're having active hemoptysis, you can't do a good job with PDT because the light is absorbed into the blood. But you won't get a lot of hemoptysis after PDT because I think it destroys the blood vessels as well. What we do is, if somebody comes in with an endobronchial lesion, we do HDR and PDT sequentially, and we get a fantastic prolonged palliation, much longer than either one alone. So we use it sequentially as a planned intervention. We do 3 weekly HDRs, and then we do 1 PDT. It works wonderfully. I would recommend it.
Any more questions?
Ron, it's a good talk. I'm particularly interested in your Chestwall PDT with Photofrin, and I didn't get your light dose for it, and so I want to ask that.
Yeah.
And also, since you are using Photofrin for low drug dose Photofrin, do you see any systemic effect, for example, or do you comment on that?
Basically, Photofrin, the standard dose is 2 milligrams per kilogram, which is a fairly high dose. And it might not be the optimal dose, but it was a dose that it was tested on in the original randomized study, so that's what the insert says. So there's no law that says that you have to use 2 milligrams per kilogram. In fact, our clinical experience was that 2 milligrams per kilogram, you had a lot of normal tissue reaction. So if you go back into the ancient history of some of the trials, there's a different series of drug doses that go from like 0.6, 0.8, 1, 1.2. You don't get much reaction at 0.6, but at 1 milligram per kilogram, you got pretty good differential. So we took the 0.8 from those studies. The light dose that we use is on the higher end. We use 135 joules, which if you use 150 joules on a chest wall, it'll burn a hole. If you use 135 joules, it won't. So even though you don't think there's much difference, there is a huge amount of difference. And then, you know, when there's angles, so who knows what the real dose is, but the calculated dose is 135 with 0.8. With a little bit of experience, it seems to work quite well. Every individual reacts differently. So you get a weeping almost immediately in some patients. You'll get no reaction in other patients, yet about 24 hours later, you'll have pretty much the same exact response. We haven't seen any systemic significant response to metastasis, but we've seen on the chest wall areas that we haven't treated respond. So there is a regional response, I'm convinced of that. And whether we're not doing it right to have a systemic immune response, I bet you it could be manipulated. But we haven't seen a systemic response. Though, we've had patients who you would have thought would have been dead within 90 days, alive 2 years later. So I think there must be something going on. It's just we treat 12 patients a year. We just don't have enough of a volume to understand what's happening. But thank you for that question. Yeah, the FOSCAN could probably be a fantastic drug, but not at the drug doses that are recommended on the, because it takes us 3-6 hours to do this. FOSCAN, you could probably do the whole thing in 30 minutes.
So
we don't have pain with 0.8 and 135. Just an ice pack. We turn the light field on, we put an ice pack on. We have
a short time for lunch, so we're going to take the last question.
If you treat mesothelioma, did you treat it intraoperatively or do you do it externally?
I'm sorry, I missed that.
If you treat mesothelioma,
yeah,
do you treat it intraoperatively?
It's an intraoperative procedure. Yeah, because of the penetration of the light, theoretically you could probably illuminate through the skin, but the reality is it's a very large procedure where they deflate the lung and move the light sources around or use a colloid. That hasn't worked out as well, although there's a Dr. Takeda who is an expert on that. So you can fly to that person and have a good treatment, but for the rest of the people, I'm not sure if they do it well. Well, thank you for your concentration. Enjoy lunch.
Okay, we will resume 1 o'clock. Okay, thank you.